speaker is Dr. Colleen Leitner, who is a consulting child and adolescent psychiatrist with the Delaware Child Psychiatry Access Program.
No financial disclosures to report. Thank you, Mindy, for the introduction. So my goal today, if you went to this talk a year ago, it's going to be very similar, really to just present a little bit of the background on pediatric bipolar. If you don't know, this is probably one of the most controversial diagnoses in child psychiatry. I'm going to define, as we do currently in DSM, and give some clinical pearls on how this looks in kids, what my differential is, how I think through clinical scenarios when bipolar is a consideration, and then present treatment options. Okay, so here is some background on the controversy. So when I was in adult psychiatry residency and I told people I would like to go into child, there were adult attendings who said to me, "Oh no, you cannot do child. The embarrassment of the pediatric bipolar situation. You don't want to do that. There's no evidence." So scientific inquiry is a process of reviewing evidence and refining it. And so this is definitely a diagnosis in which we have recently done that. And so there's been a lot of discussion over the last 20 years academically, but also in the general public. So this is a concept that is very much, if you're working with families, they have their own ideas about what it means to be bipolar. And the changes that we've made really have been to narrow the definition of mania recently in the last 10 years or so. So everyone agrees pediatric bipolar exists, but the bipolar itself is similar to how it presents in adults. So it's not a separate diagnosis. It's not separate diagnostic criteria. And yes, we can diagnose it in kids. Oh, and some of my sort of shout outs here. So the sensationalism. So this 2002 or 3 Time magazine cover, the volatile young and bipolar, and this poor child. I don't know how they got him to model. And then a 2008 documentary that was a little bit incendiary called The Medicated Child came out on PBS, and it basically talked about the intersection of scientific inquiry and big pharma. And it was suggested that the increase in pediatric bipolar coincided with an increase in atypical antipsychotics and a lot of money made for pharma. So that was presented. And then an academic child psychiatrist wrote a book called Your Child Does Not Have Bipolar Disorder. So definitely something that's been discussed and highlighted. So some context for this. How did we get here? Before the 90s, if a kid presented with any sort of psychosis, we universally said, this is schizophrenia. Obviously, we were missing some things, and there were some retrospective studies in adults done that basically said, do you think when you were younger, you probably had mood episodes? And people said yes. And so there was an effort to define a new pediatric bipolar syndrome. So we had a 40-fold increase in diagnoses for something that's really, really rare. And so a few things happened around that time. There were changes in DSM for how we define ADHD. So we took out emotional dysregulation, which had been a core ADHD symptom. And if you're working with kids with ADHD, we know problems regulating emotion goes along with ADHD. But we took that out of the DSM, so it was no longer considered part or attributable to the ADHD. And so we started labeling these chronically irritable kids with or without ADHD with emotional outbursts as having bipolar. And yes, a rise in these diagnoses, if all you have are hammers, everything starts to look like a nail, overlapped with a rise in atypical antipsychotic prescriptions. There is a lot of outcry. 2013 DSM-5 comes out and they made significant changes. So they narrowed the definition of mania. The focus now is on the classic clinical course of bipolar disorder, as it has always been. And then they added a new diagnosis, disruptive mood dysregulation disorder, or DMDD. DMDD is essentially kids with chronic irritability and developmentally inappropriate outbursts or tantrums that happen several times a week. And so that diagnosis was created to try to capture those kids that had been mislabeled as having bipolar. So where do we stand with the symptoms? What do we mean when we say bipolar? So mania is the same sort of as it ever was, the dig fast mnemonic I learned in med school. So distractibility, the key here is more magpie-like. Kids with ADHD have a short attention span. They have problems with executive function. The key here is being drawn to irrelevant stimuli. Impulsivity, not just not thinking through decisions, but a pursuit of pleasurable activities. The example I always give is I had a college student who was sort of typical college guy. He was in a fraternity. He was smoking some weed, drinking beer with his friends, going to parties. When he became manic, he spent like $20,000 at an antiques fair. He bought all these like weird statues. And weird to him, when he was no longer manic, he was like, I have no use for these. I have no idea why I decided to buy those. He just got caught up in sort of the auction. Grandiosity, this could be inflated self-esteem. Many teenagers will sort of be braggadocious. What we mean here can sometimes be delusional. So I have special powers. I am associated with famous people or connected to them, or even I am a god, or I am a channel through God. I am the Messiah. Flight of ideas. The key here is it's not Gilmore Girls rapid speech. Some of us, including me, are fast talkers. It's more that it's difficult to follow. Someone with a sort of average intelligence can't keep up with the flow of the thoughts. They don't quite make sense. There seems to be a loosening between the connections between ideas. An increase in goal-directed activity could be anywhere, or psychomotor agitation. So I think of a purposeless movement like a rocking chair. The classic would be, okay, you have this grandiose delusion, you are the Messiah, you're writing your manifesto all night and pacing as you do so. A decreased need for sleep. So not just I have problems falling asleep or I'm not sleeping as much, I'm tossing and turning, but you feel rested, you are ready to go after not sleeping at all or a few hours. And then talkativeness, being more talkative than usual or pressure to keep talking. When I say pressured speech, I mean I cannot interrupt this person, not necessarily that they have a staccato cadence.
Dr. Leitner, could I ask a question?
Yeah.
Are there any of those symptoms that might be confused, just a very small group of them, with psychosis? Sort of paranoia or, inflated ego or,
So any of them can
reality, right?
So I would say like grandiosity can become grandiose delusions. Flight of ideas, if the thought process is no longer linear and understandable to an average person, that's sort of my litmus test for psychosis, right? So it's this change in thought process that no longer makes sense to the person listening. That in and of itself is psychotic. Does that answer the question?
Yes, thank you. It was my question.
Okay.
So, thank you.
Yeah. So DSM-5, I'm not going to read this whole thing, basically takes these dig fast criteria and adds some caveats. A is the key to all of this and what we sort of missed when we were over-labeling bipolar. So we need a distinct period of a change in mood, be it elevated, expansive, so you're up. That's the classic mania, is you feel really, really good, amazing, or irritable. That would be a more mixed picture. And an increase in goal-directed activity, so you're doing lots of stuff for at least a week, most of the day, every day. So this is not 10 minutes, it's not an hour, it's a week or more, and often it's more. During that period, you have to have 3 of the dig fast symptoms. 4 if you're irritable. It has to be a noticeable change, as in noticeable to others, not just subjectively noticed to the person. It has to cause marked impairment in occupational, social functioning, or you're hospitalized or psychotic. And then it can't be due to directly a substance or another medical condition. So once you meet mania criteria, you meet criteria for bipolar 1. Depressive or hypomanic episodes are not needed, though often they go along with this. And often what we'll see is we'll sort of have somebody with a previous depressive episode, and then, maybe they don't respond to treatments. Then later on, they present with mania and we say, oh, this is what we didn't realize when we were attempting to typically treat your depression. It wasn't a major depression, it was a bipolar depression. Hypomanic episodes will often occur as well, and sometimes they'll precede a full manic episode, but are also not needed to diagnose. Bipolar 2, on the other hand, this one, I think especially in adults, has sometimes been used when there's just a feeling of moodiness. You really need to have met hypomania criteria, which I'll explain in the next slide. And then you also need major depressive episodes, in contrast to bipolar 1. Most of what I'm talking about treatment will be bipolar 1. There's very little data for bipolar 2 in kids. Overall, I would say similar treatments apply. It's just sort of less severe symptomatology, and we would consider this sort of along a spectrum. But it's not just a whiff of symptoms. It needs to meet these criteria. So hypomania, very, very similar to mania. The period is 4 days instead of 7. Same as the B criterion. So you need 3 of the dig fast symptoms, 4 if you have an irritable mood. Still has to be an unequivocal change in functioning observable by others. So again, a subjective, oh, I had 4 days where I felt like I was feeling really good. No one else noticed and it didn't impair you in any way. It does not count. With that said, it can't cause severe impairment and be hypomania. Like if you're hospitalized and psychotic, even if it's only been 4 days, by definition, you're going to meet mania criteria. Yeah, cannot be due to substance or medical condition as well. So how does this usually look? Most people with bipolar prognostically will do very well. So you will have a baseline where you are quite stable, and then you have these recurrent mood episodes. We treat maintenance treatment, so even when you're not in an episode, to prevent episodes from occurring. Mania is supposed to be a collection of these concurrent symptoms with the mood shift, not just a list of symptoms. So if you're taking a history and you're asking about, oh, have you ever felt this way? Have you ever been, felt like you were on top of the world, you're grandiose? If you just go over those symptoms, if they've ever occurred at all, you will get a lot of false positives because people will recollect these happening. They have to occur all at once and be observed by others. Untreated, mania will typically last several months. So the time course on this is significant. And sometimes even in the hospital, we'll have people in there for weeks, months. We're giving them, tons of medication therapies for which we have evidence, and it just takes a while to consolidate. So the course of this, I think that's probably the thing people miss the most. The sort of lay understanding of bipolar is I have a 0s to 60 shift in my emotionality, and that means bipolar. But for me, the longer the change in emotionality, the more significant and the more that's sort of predictive for me. The most rapid cyclers, so the 10% of individuals with bipolar disorder that cycle the most, that's 4 or more episodes a year. So that's on the course of, every 3 months you have a shift, not every 3 minutes. When psychosis does occur, it needs to happen in the context of a mood episode. So sometimes I'll get referrals that are like, oh, this kid's sort of, hearing voices, maybe they're telling them to harm themselves, but it's not associated with a mood episode. That is unlikely to be bipolar. That is probably something else. So it should be those sort of delusions associated with that mood presentation, and it should go away. So things I'm thinking about when I'm making a diagnosis of mania. Number 1 through 10 is, what is this kid's baseline? What are they usually like? Remember, we need this distinct, discrete period that it can sort of carve out of their history. And so it changed from their usual mood and behavior. It has to understand sort of what is their usual mood and behavior. Beware, especially with impulsivity and irritability. Impulsivity, lots of kids are chronically impulsive and trying to separate out, okay, yep, you spent some money you didn't have, but was that in the context of a mood shift? And is that something you wouldn't usually do? Is really important. And irritability as well. Pretty much any psychiatric condition in kids can present with irritability. Teenagers themselves can be irritable. Trying to figure out, was the irritability a significant shift, and was it temporally correlated with these other manic symptoms? Where they are in development is important. There is a natural increase in emotionality as school-age kids go on to middle school. That's something we sort of expect. And so is it sort of part of an increase in emotionality that's naturally occurring, or is it more severe and impairing? Context is key. So kids will tell me all the time, oh, I was feeling manic, but I masked. You cannot mask mania. So true bipolar 1 mania, it will be noticeable to others by definition, right? So it should happen regardless of context. It should be happening at home. It should be happening at school. It should be happening to, places where people don't want these things to be happening. And often there's not a lot of insight. So commonly, if someone is manic and psychotic, they really don't know they feel amazing. They don't know how far off they are from how they usually are. And so collateral is really important in understanding how this kid's been impacted and what's going on. And then functional impairment is key, as it is for every, psychiatric illness. So some examples. If you met a group of teenagers riding roller coasters at Disney World, you might think they're a certain way. You might be like, oh my gosh, these kids are totally manic if they behave the way they do at Disney at school, say. But that's the key, is that contextually we should change our behavior, how we regulate our affect and our energy level based on the context. And so that context is important, always understanding the context and what other people are noticing. We talked a little bit about the natural developmental shifts. Infants entering toddlerhood is a great example where we have a developmental shift in emotionality. We have these sweet babies, and then suddenly they have all these big feelings. Irritability, I think I cannot hit home enough. Sometimes there will be contextual irritability, and we're trying to figure out, is this really episodic? So if a kid is irritable only during the school year, things I'm thinking about, is this an anxiety and they're anxious about school? Or is there some sort of trauma? Are they having repeated exposure, a reminder of a trauma that's only occurring during the school months? It's less likely when it's associated with a context to be mania. Some notes on antidepressants. So antidepressants, including SSRIs, which are a mainstay antidepressants in kids, can bring out hypomania in kids who have a bipolar diathesis. DSM-5 is very clear on this. If you give an SSRI, you stop it, and they're, quote, fully syndromal with mania, like they're still fully manic even after you stop it, that's enough to say, this is not substance-induced, this is mania, you have bipolar. But they urge caution. If you only have a couple symptoms and there's sort of a little bit of irritability or edginess with an antidepressant, that is not hypomania. That does not mean you have bipolar. Kids especially. So 10 to 20% of kids, if you give them an SSRI, they're going to have an increase in energy. They might have some other symptoms of what we call activation, where they might be more irritable. I've seen kids like one jumped off a picnic table, behavior that was just very atypical for them. This is common. This does not mean, one, that they should be diagnosed with bipolar disorder, nor that you should avoid SSRIs in the future. We see this more with fluoxetine or Prozac. And so if somebody didn't tolerate Prozac, I might switch to a sertraline or Zoloft, which tends to have a little bit less activation. Okay. Now I'm bringing this case example. So this is from a study that came out in 2008. In the US, we had this 40 times increase in bipolar diagnoses, not so in the rest of the world. And so this British group was basically like, what is going on over there? So they polled child psychiatrists in the UK and in the US. They presented them cases, and then they compared the portion that declared that patient cases had bipolar disorder. So this was the classic definition they gave. Nicola, a 12-year-old, previously shy, helpful, doing well academically, has a sudden onset of behavioral changes. So for a couple weeks, she's been dressing provocatively, talking to random people on the phone and internet. She has energy around the clock. She has some mood lability. So she's laughing 1 minute, smashing things, crying without provocation. She has a history of depression. When you see her in the waiting room, it is obvious that she is not well. She's speaking loudly and rapidly. She's expecting a phone call from someone famous. Has this goal-directed activity increase. She's organizing toys, yelling at parents. She's suspicious, a little bit paranoid on interview. She's a family history of depression and postpartum depression. So this, in almost every way, is sort of that classic bipolar. She's very young. She has a little bit of a mixed picture. So she has irritability and mood lability, which is a little bit less usual than a pure mania where you're just totally euphoric. But the clinical course where she is previously well and then suddenly develops significant symptoms is classic bipolar. So 90-something% of both the UK and the American psychiatrists diagnose this kid with bipolar based on the case. In contrast to this case. So Linda, she's 11. She's been hyperactive, disinhibited, and impulsive since preschool. She was on some stimulants, didn't have a full resolution of symptoms. She's very oppositional, has problems with peers because she bosses them around and is in their business. Over the past year, her symptoms have gradually gotten worse. So she's more angry, irritable, she's provocative, she's bullying little kids, she's looking at lewd stuff online. So there is this hypersexuality maybe. She's a show-off, she's silly, she repeats jokes. When she doesn't get her way, she rages. She screams, curses, she throws things. She's threatened others with a knife, and she's had to go to the psych ED. When you interview her, in contrast to the previous case, she is calm. She is disrespectful to her parents. She can focus when you ask her questions. She does try to control the narrative of conversation. She says, oh yes, I'm distractible, I'm forgettable. I'm suicidal when I get upset, and my mood is just all over the place, a lot of mood swings. She denies any euphoria. She says, oh, yes, my speech is rapid, but when you observe, you don't see this. She's also reporting insomnia, but it sounds like she more has a delayed sleep onset. She goes to bed at 1 and sleeps until the late in the afternoon. She has some history of tobacco and cannabis use and has a family history of depression, hypomania reported, and ADHD. So this case was 2008. A majority of American psychiatrists said bipolar, and none of the British psychiatrists did. So this represents something else. And the key for me when I compare these two cases is the baseline. So Linda has always had problems with regulating her emotions. They've gotten gradually worse over a year, but there's not that sudden and acute shift of manic symptoms with a change in mood. So Linda now would meet criteria for DMDD, and that's part of the logic that went into creating the DMDD diagnosis. So how does this look? About 1% of adults have bipolar illness. A highly recurrent and remitting course is classic. The prevalence varies since we've recently updated our diagnostic standards. Recent data says about 0.6% in adolescents, so even lower for younger children. The average age, we think of mania as a sort of a presentation in early 20s would be classic. Schizophrenia is a little bit earlier. It's part of why they were sort of diagnosing that earlier psychosis as schizophrenia. It's more of the late teens. Retrospective self-reported hypomanic symptoms are common in adolescents. So if you ask adolescents and you go through Dig Fast and say, have you ever had these? The majority will say yes. Anyone with onset less than 18 with a bipolar diagnosis, regardless of how narrowly or broadly we define it. I mean, I think Linda is a good example. No, she doesn't meet criteria for bipolar disorder, but clearly she requires significant mental health support. They have a slower response to treatment. They're at elevated risk for suicide attempts and severe psychosocial impairment. In terms of comorbidities, in classic bipolar 1, anxiety and sleep disorders will precede the diagnosis. Depression will often come first in terms of mood episodes. We'll mislabel it unipolar, like I mentioned. Peripartum depression, for those of you working with families, is really common in bipolar 1, up to 50%. So definitely something to be screening for. In more broad definitions of bipolar, so like the 90s 2000 definition, 90% of kids with prepubertal, I'm putting mania in quotes, met criteria for ADHD and ODD. But in the classic definition, the one we go by now, ADHD did not occur more commonly. Substance use occurs more commonly, sort of regardless of how we define. This can be hard to sort of suss out. I mentioned my fraternity brother who presented. Cannabis can precipitate mania, and so for anyone with a history of mania, we want them to avoid cannabis and stimulant use. There is significant genetic influence for bipolar 1, so it's 60 to 93% of the variants, depending on the twin study. When we look at family trees, though, common things being common, major depression is usually what shows up. So it's not necessarily that bipolar 1 clusters. It seems to be depression and bipolar together, which we think of them as totally distinct entities, but they do seem to cluster together in families, mood disorders generally. There's a lot of interest in uncovering brain mechanisms. The research is hard, right? People that are well treated and able to sort of participate will have long periods where they don't have symptoms. And then when they do have symptoms, it could be mania, a mixed episode, or a depressive episode. There's some data to support the structures that regulate our emotions, the amygdala, anterior paralimbic cortices, and the connections between them as supporting or contributing to the bipolar diathesis. So what's on my differential? The first three, ADHD, disruptive behavior, and DMDD, we think of the Linda case. Linda probably has an ADHD and DMDD diagnosis. There's a lot of overlap with ODD and DMDD. Attend our disruptive behavior disorders lecture we gave a few months ago. We covered that in detail. Unipolar depression, we've mentioned a few times. I can sometimes have an anxious depression that will mimic a mania with sort of mixed features. People with anxiety can have a lot of goal-directed behavior and significant insomnia, and it can almost look like they're manic. Kids with autism, especially depending on their verbal abilities, they might have a stressor that's unknown to us, and it will appear that they're having an episodic mood sort of disorder with an increase in aggression. But often, if you're able to do sort of a functional behavioral assessment and understand what's going on, we can sort of peel back the layers. Not that kids with autism can't have mood disorders, certainly they can. Schizophrenia, the thing we'd be looking for there would be psychosis independent of mood episodes. Substance use, kids with substance use problems will have changes in their mood depending on whether they're using or withdrawing. Some substances can contribute to things that look like mania. And so that's always on our differential. It's particularly in adolescents and adults. Borderline personality disorder is on my differential for bipolar. At its core, it is emotional hypersensitivity and an unstable sense of self. And so sometimes that can mimic a bipolar or manic presentation. Medical problems. This is relatively rare. I would say hyperthyroidism, I've seen do it. A few other things can present similarly, like an NMDA encephalitis if you read Brain on Fire. But there will usually be, signs in terms of vitals and labs and things like that. Medication use, corticosteroids, so a prednisone burst, I have seen it a lot, particularly in adults, and stimulants, even at our typical doses, can precipitate mania as well. Trauma. This I cannot star enough. So kids who have been traumatized can have impulsivity. They can have shifts in their mood. This can depend on just, where they are and re-experiencing or being having repeat exposure to trauma. They can present with symptoms that will appear to vary in a way that could mimic discrete mood episodes. So screening for trauma is important. When I'm thinking about ADHD versus bipolar, there's a few distinctions that are key. Kids with ADHD are going to have this silly, disinhibited baseline. Bipolar 1, again, we need this change. Kids with ADHD will be impulsive. Bipolar 1, that impulsivity is pleasure-seeking. Kids with ADHD often don't want to go to bed. They have all this energy. In bipolar, you have a change in how much sleep you need. So whatever your baseline sleep was, that's going to change. And you're going to do all this planning all night, which is not typical for ADHD kids. We might have a shift where a kid with predominantly inattentive ADHD symptoms was not diagnosed. And then when they go to middle school, suddenly it seems like they're daydreaming more. It's harder for them to keep up. In bipolar 1, remember, we'll have this actual shift in how they are thinking and how they're moving through the world with a flight of ideas. ADHD kids can, sort of like Linda, she was first diagnosed with ADHD in preschool, progress to include more oppositional or explosive behavior. Bipolar 1, the irritability should be confined to these mood episodes. People with ADHD often are very talkative or they have rapid speech. Again, bipolar, it's not just that you're talkative, it's that you have thought changes. Conduct disorder or other disruptive behavior disorders can also mimic mania. Kids will often be irritable as well. They might stay out late. So it's, do they need less sleep? They might be engaging in sexual behavior and substance use. And the way that sort of callousness or disregard for the rights of others can appear to be grandiosity. The key here is sort of fitting in the symptoms with a change in mood. So if behavioral problems are only happening when they're manic or depressed and disappear, you can't make an ODD or conduct disorder diagnosis. And then think about bipolar if the kid's oppositional symptoms are only happening in their mood disorders, mood episodes, and it's totally out of character. You can give both diagnoses, and that does happen. So similar to the autism thing, it's not that kids with conduct disorder couldn't have bipolar, they certainly could, but you want to clearly chart, what was their baseline, when were the onset of these symptoms. Okay, here's an example. So this was several years ago now, when I was working at a state hospital. This was a kid who came in with mania. He was convinced that he was going to become like a really famous fitness influencer. And so he would stay up all night writing his schedule and his workouts. And this was some of his earlier, maybe he was there a couple weeks at this point, writing. And so this is just a really great example of how his ideas did not connect in a way that was understandable to me. So at the top, he wrote that he had this meeting at 7 a.m., which even the way he wrote the time is like jumping, right? He wrote 7 a.m. : 00. So he's moved forward to the a.m. before he put the 00. Then he's making a schedule, right? So he wrote a.m. It's cut off a little bit under that a.m. where the arrows are. It's supposed to say sunrise to p.m. And then he went from sunrise to subset. So he's a really smart kid. And then underneath subset, where he wrote 3 digits - 4 digits, 3 digits to 2 digits. So, he knows subsets are math, and then he's thinking about the number of digits things have. I have no idea what that had to do with his line of thought. And then he's going back to the sunrise thing. So orange, sun, SunTrust. SunTrust is bank. So taken together, I have an idea that he has thoughts about various things, numbers, his schedule, colors, the sunrise and set, banks and numbers, but they don't go together for me in a way that's remotely linear or understandable. And he had just pages and pages. He would just fill notebook pages with this and be like, look what I've done. And we'd be like, I wish I could understand, but I don't. This is when he had become a little bit more linear. So the bottom half, he had a little bit of paranoia. He had no insight. He had no idea why he was there. And he was very perseverative. This was in COVID. And so he was very focused on my COVID test was normal. So he wrote down my name on that left side, Leitner, Colleen, CCCA. Why he wrote invert in my first and last name, I don't know. And then he wrote about the team that was rounding. I'm like, who are these people? I gotta remember this. Dr. Light here, that was me, which I did not refer to myself that way. So I think he just got confused about Buzz Lightyear. Dr. Bond, and then 3 Dr. Boy. We're all women. It was myself, Dr. Bond, and the social worker, Chelsea. And then he wrote Head and Shoulders, which I don't think was a shampoo reference. I think it was a reference to the body parts in his workout routine. And then he wrote COVID normal, left, and I don't even know left and left. I think that was probably back to his workout thing. So again, he's like trying to get the picture of like, okay, why am I here? Who are these people? And then he's going back to his perseverative thoughts about the workout routine. And then the top was actually what he tried to present it to us as a workout team. So on the left, he wrote boulders, front, middle, rear, dips. And boulders, he told me later, are these sort of aspirational shoulders. You want them to be so hard they look like boulders. So that I don't think was psychotic, but that was sort of weird. And then he wrote that he was going to do dips. So he was going to do front, middle, and rear dips and do 18 of them. And that sort of makes sense. But then you see at the top, he's like talking about shoulder dips. And then he wrote 16 plus gluteus maximus, 1 spina rector. So he's just like free associating different muscle groups. Again, it's more linear than before. I can see he's trying to build a workout routine. He's writing numbers. His math adds up. He's writing different body parts, but it's just not intelligible. So this shows just sort of how psychotic you can be in the setting of a manic episode, just jumping from one thing to the next. His increased goal-directed activity, he's thinking all the time about his fitness plan, but it might not, the more intense you are in the episode, it might not make sense to others. All right, so what do we do? Moving on to treatment. This is one of the only disorders in child psychiatry that I will say medication is first line. There is benefit to psychosocial interventions, but in addition to medication. When we do research on treatment, we divide it into acute treatment of mania, acute treatment of depression, and then maintenance treatment. So it's sort of what you continue to take. Atypical antipsychotics have considerable effectiveness in our trials. Divalproex or Depakote and lithium have more mixed results, especially compared to adult data. Those are our mainstay mood stabilizers in the adult data. Lithium, especially if you give an adult with bipolar disorder lithium, 1/3 of those adults will not have a mood episode for 10 years. So people can really do amazingly well and be very stable on this medication. And then I think average between mood episodes, if you're stabilized on lithium, is 3.5 years in that range. So like I said, you can do very well. We don't have that data for lithium right now for kids. There is no indication for oxcarbazepine, carbamazepine, or topiramate if pediatric bipolar is the diagnosis. So some psychosocial treatments that have the best support in terms of data, child and family-focused CBT, just family psychoeducation, talking to families about what is this disorder, what can you expect, what is this going to look like. Family-focused treatment for adolescents and DBT for adolescents. So mania. This is where we have the most data in terms of pharmacologic treatment, though you'll see a lot of the funding for studies was in the 90s and 2000s. It was a great time for industry funding. And so the broader definition of bipolar was being used. So lithium and 5 atypicals have FDA approval for mixed or manic episodes in kids. Ziprasidone or Geodon, I would say, also has a positive trial. Any atypical I would consider using depending on what they've tolerated and things like that. Industry-sponsored trials for carbamazepine, oxcarbazepine, and topiramate were negative. They kept trying to compare atypicals to Depakote. They did Seroquel or quetiapine and risperidone comparison, and the response rate to the atypical was in the 60 to 70% range. The rates for Depakote were really poor. So 24% in one of them, 40%, 45%. So we're really not even beating placebo some of the time, which is much lower than our adult data. The team study, which was published in 2012, so right before that DSM change, probably the most low study in child psychiatry, depending on who you talk to. The study sample had a 90% presence of comorbid ADHD and ODD diagnoses. So this was probably a lot of LIMDAs when you think about those two cases. The lithium response rate was 36%. So compared to the adult data, where we have a third of people that will have, 10 years of amazing response with no mood episodes, a third of people just didn't even have, or we only had a third of people respond at all. So this study was much talked about and mentioned in the changes that went into the 2013 DSM. Adolescent onset classic mania has demonstrated lithium responsiveness. So if I have someone who is presenting with very clear-cut mania, I do have no problem sort of recommending lithium. For depression, trials are more limited. Olanzapine plus fluoxetine in combination has the best response rate. So though fluoxetine or Prozac can cause a mood shift into mania, if one is appropriately mood stabilized, so in adults, we will classically do like lithium with an SSRI, though sometimes an atypical plus an SSRI if they're not able to take lithium or another more classic mood stabilizer. So that combination had a high response rate. Lorazepam or Latuda also has a decent response rate and has a more favorable metabolic side effect profile. Quetiapine was not better than placebo in kids with bipolar depression. And in general, like I said, the use of an antidepressant alone plus lithium or Depakote is less useful in kids than in adults in our recent studies. Same thing with maintenance. We don't have enough head-to-head comparisons between agents to have clear guidelines. In practice, most kids, if they have a bipolar diagnosis, are going to remain on an atypical antipsychotic. Lamotrigine, which is a really great mood stabilizer for adults that tend to have more depressive episodes, has mixed results, possible benefit. And then patients stabilized on lithium had a lower risk of relapse compared to placebo. So still a consideration for maintenance, I would say. So in summary, pediatric bipolar is characterized by discrete episodes of mania and depression. We've made some changes to the diagnostic criteria, emphasizing these mood episodes rather than sort of a list of symptoms of mania. Think about sort of the Linda case, ADHD and disruptive behavior disorders in your differential. Regardless, this is a disorder to take seriously. This is associated with a significant functional impairment and suicidality. Atypical antipsychotics are probably our mainstay treatment. Lithium has some support. More research is needed. Just a resource spotlight, ACAP, our American Academy of Child and Adolescent Psychiatry, has a medication guide for families that's pretty helpful and goes into side effects and just helpful family points and references.